Thank you for joining the 12th Annual PIPC Forum. It's hard to believe that it's been 12 years. I'm grateful to see our progress advancing the voices of patients and people with disabilities in research and healthcare decision-making. We have come a long way, but we have much more to do. The United States Congress passed the Americans with Disabilities Act over 30 years ago because of one thing: disability is not unique to any political party or demographic. My friend Bob Dole, a disabled World War II veteran, recently passed away and reminded me yet again the importance of this fact. Bob said, "Having a disability changes your whole life, not just your attitude." When I think about some of our greatest achievements in the disability community, they are often the result of what unites us. A quarter of the population is disabled, and half the population is connected to disability somehow. That means many people understand the value of accommodations and the need for policies against discrimination. Because of great people like Bob Dole, the ADA had bipartisan support. Later, the Patient-Centered Outcomes Research Institute, or Bigquery, was created because members on both sides of the aisle came together to draft the original bill that was eventually included in the Affordable Care Act. Today, we hear from the chairman of the National Council on Disability, an important federal agency, about its work to advance the promise of the ADA. I can say without a doubt that their work has been tremendously influential in everything that we do at PIPC. When we were working with Congress to pass the legislation creating Bigquery, we thought that the bar on using quality adjusted life year by Medicare was enough. However, the National Council on Disabilities report in 2019 told us we still had work to do. The use of QALYs rising and not falling means that we were seeing discrimination in healthcare rising, not falling. Discrimination is not always out in the open. When decisions are made about people's access to care based on averages, those of us who are not average are disadvantaged. Treatment may be more beneficial and critical to us than average patient. That is why we wanted so badly for Bigquery to be created and to focus its work on how treatments impact different people. We wanted information on what works, for whom, and why. We not only need to fight for more information that helps us personalize our care, we must fight against policymakers and payers using information about the averages to limit or restrict what we care and can get. Having epilepsy myself, I understand this all too well, since I must change my medications when they stop working. We know from our own surveys of people that regardless of political party, people want to receive the health care that their providers determine will achieve their goals. They do not want cost effectiveness to drive decisions about our care. When that happens, we are telling people living with disabilities and chronic conditions, people with expensive care needs, that we aren't worth it. In my view, this is a violation of the ADA and Section 504 of the Rehabilitation Act. I'm willing to fight to do everything I can to support the National Council on Disabilities efforts to get a full ban on the use of discriminatory metrics like the quality adjusted life year in the Build Back Better bill, and to do what I can to support their recommendation that disability rights laws are enforced against the use of these discriminatory metrics in Medicare and in state Medicaid programs. I would add that people with disabilities need to be engaged partners in decisions made about the value of their health care. I'm grateful that Democrats and our Republican colleagues are with us in this fight. President Biden has stated his opposition to the quality adjusted life year. The DNC platform explicitly opposes its use. Senators of both parties have written letters acknowledging their historic discrimination using discriminatory metrics like quality-adjusted life years. With such tremendous public and political support, I hope we can come together to advocate alongside the National Council on Disability to, as they say, unambiguously ban the use of discriminatory metrics in value assessment from being used in federal programs like Medicare and Medicaid. And I want to personally thank the chairman of the National Council on Disability, Andres Gallegos, for presenting to you, our audience, today about their work. If you've not read his piece from earlier this year in Health Affairs, I would urge you to do so. He captures the stigma that leads others to view us, disabled people, as having a low quality of life. And he outlines explicit steps to ensure that we do not devalue disabled lives in our policies. He's carrying on the fight for people with disabilities, and I could not be more grateful and proud of him. In closing, I appreciate all of you for being here and for listening. I hope you will join this fight with us. Thank you.
Greetings from the National Council on Disability, the federal government's independent, nonpartisan advisory body that informs the work of Congress and the administration. We speak on behalf of the interests and concerns of the over 61 million people with disabilities in the United States and in our territories. I am Andres Gallegos, NCD's current chairman. It is my distinct honor to join you to briefly explain NCD's latest engagement on this incredibly important topic, the dangers of the use of quality-adjusted life years, or the QALY. NCD first engaged this topic of the QALY in 2019 as part of our bioethics series of reports. Admittedly, health economics can be an intimidating one to engage. If you're looking for a primer on the topic, I encourage you to read our report, as it is a good introduction to the issues. You can find it at ncd.gov. In that report, we sought to make the case that QALY perpetuates unequal access to medical care, including life-saving care. In our report, we document the inability of patients with disabilities to access life-sustaining, life-saving, and life-changing medications in countries where the QALY is used. When health insurance will not cover medically necessary medications and treatment, individuals experience poorer health and lower life expectancies. Said differently, the QALY perpetuates health inequities for people with disabilities. Not only does it have a discriminatory effect, the QALY discriminates in design as well. It is a pricing methodology that devalues the lives of people with disabilities. The calculation relied upon by the QALY reduces the value of treatments that do not bring a person back to perfect health, in a sense of not having a disability and meeting society's definitions of healthy and functioning. In that school of mathematics, you can imagine how disadvantaged scores of people with disabilities truly are. Shortly after I became chair of the National Council on Disability on the afternoon of President Biden's inauguration, I announced my vision for the council during my tenure as one that would stay focused on achieving health equity for people across all categories of disabilities. It's my sincere belief that health is the predicate for improvements in living, learning, and earning for people with disabilities. I began my tenure as chair approximately a year into this global pandemic, a pandemic that has unmasked the extent to which explicit and implicit bias against people with disabilities affects treatment decisions. We saw states like Alabama, Arizona, Kansas, Pennsylvania, Tennessee, and others establish crisis standards of care. Guidelines for the use of scarce medical equipment, medication, supplies, and personnel that would expressly base triage decisions on normative quality of life judgments. or that excluded from treatment patients requiring assistance with activities of daily living, or those with certain conditions such as severe or profound mental retardation, those are their words, moderate to severe dementia, and pre-existing conditions that are disabilities. Now I want to be clear. The NCD is in favor of supporting lower drug prices. People across America, including people with disabilities, need access to lower prescription medications. High drug prices themselves can be a significant, if not insurmountable, barrier to access quality health care. But we are not interested in giving policy advice that trades one barrier for another. However, the pursuit of lower drug prices should not be borne on the back of any group of people, and particularly not people with disabilities. We already have a formidable history of experiencing inequities in accessing health care. Misperceptions of people with disabilities on the part of medical providers already lead to low quality of care. There's a horrifying, extensive body of research proving this. In fact, in a recently published survey, it was revealed that 82% of physicians in this country believe that people with significant disabilities have a lower quality of life than non-disabled people. 82%. That's shocking but not surprising for those of us with lived experience accessing healthcare. Here's the shameful reality. Today in the United States, if you're a person with a physical, intellectual, or developmental disability, your life expectancy is less than that of someone without disabilities. As compared to our non-disabled counterparts, you are at a higher risk for early onset of cardiovascular disease. You are more than twice as likely to be obese. You are more than 3 times likely to have diabetes. You are significantly more likely to have unmet medical, dental, and prescription needs. These disparities are exacerbated if you are disabled and a woman, or disabled and a person of color. The existence and extent of these health disparities often have nothing to do with disabilities per se, and are often preventable, but they have everything to do with how physicians see us and how they treat us. Explicit and implicit discriminatory bias within healthcare professions represents an insidious virus against which people with disabilities have been fighting for decades. Where it is used, the QALY is an additional embedded bias, cloaked under the virtue of cost savings. Now, what may surprise some is that QALY is not a new idea in the United States, nor is the understanding of its discriminatory design and impact. When Oregon first attempted to use QALY in its state Medicaid plan in the 1990s, CMS rejected the plan, finding that it violated the Americans with Disabilities Act. And the history of restricted access to treatments occurring in countries utilizing QALY raised concerns that its use here in the United States would result in rationed care. That led Congress in 2009 to prohibit or severely limit its use by certain federal agencies under the Affordable Care Act. The language in the Affordable Care Act stated that the Secretary of the United States Department of Health and Human Services shall not use evidence or findings from comparative clinical effectiveness research in determining coverage, reimbursement, or incentive programs in a manner that treats extending the life of an elderly, disabled, or terminally ill individual as of lower value than extending the life of an individual who is younger, non-disabled, or terminally ill. It instructed the Patient-Centered Outcomes Research Institute to not develop or employ a dollars per quality adjusted life year or similar measure that discounts the value of a life because of an individual's disability as a threshold to establish what type of health care is cost effective or recommended. In our most recent advice to Congress, we advise that Congress extend those prohibitions throughout federal programs. The Build Back Better Act is a tremendous opportunity to do so and to memorialize the protections with an unambiguous ban of the use of QALY. We remain hopeful that our advice will be heeded as we all await the final text of that bill. I will close with my remarks here with a statement that summarizes NCD's advice to policymakers regarding the use of QALY. Decision-making tools designed around measures that devalue the lives of people with disabilities are discriminatory. They have no place in modern disability policy, particularly in light of our current administration, whose leadership has rightly emphasized the importance of achieving and advancing equity. I want to thank you for the opportunity to share my comments with you today.
Hello, and thank you for having me. I'm Caitlin Mccormack, the Associate Director for Public Policy and Government Affairs here at Bigquery. I wish I could be with you in person today, but I'm delighted to deliver this message to your forum. The relationship that Bigquery and PIPC have enjoyed over the years is so important for the health research community overall. I thank you for your partnership and support all these years. I don't think I need to introduce any of you to Bigquery, but I will mention that over our more than 10 years of funding research, we have now committed about $3.3 billion to more than 1,800 research, dissemination, implementation, and engagement projects focused on comparative clinical effectiveness research, infrastructure projects, including the Patient-Centered Outcomes Research Network, and projects focused on the methods used for our funded research. This year, we launched a strategic planning initiative that will determine the kinds of studies we fund in the future and will help us do our part in reshaping the U.S. healthcare system. And groups like PIPC are critical to us as we engage in this process. And throughout this time, we have sought and will continue to seek input from a wide variety of sources and stakeholders, including all of you. Today, we are focused on a critical process to moving Bigquery forward, updating our national priorities for health and our research agenda. Over the past year or so, Bigquery has developed our new national priorities for health, a set of high-level priorities that will drive our detailed research agenda for the next phase of Bigquery's work. After a robust comment period, our board approved the following as our new national priorities for health: increase evidence for existing interventions and emerging innovation in health, enhance infrastructure to accelerate patient-centered outcomes research, advance the science of dissemination, implementation, and health communication, achieve health equity, and accelerate progress toward an integrated learning health system. This set of aspirational goals will update the national priorities for research that have guided our work this far. Moving from priorities for research to priorities for health is significant, and that the focus is now more on outcomes than on the process for achieving them. You'll note that all of these priorities begin with a strong action verb like advance, accelerate, and achieve. We believe these kinds of words will provide North Stars to guide us in making funding decisions that will provide evidence needed to achieve these goals. We anticipate that this shift towards achieving health goals will also entail partners beyond the formal healthcare system, such as in the fields of education, public health, and housing, all of which play a role in community and individual health. These national priorities will chart Bigquery's course for the next phase of our work, and I think will provide many opportunities for further collaboration between our two organizations. With our national priorities for health in place, we have turned now to developing our research agenda. Our draft research agenda has been approved by our board and is now available for public comment. Our research agenda provides a framework for achieving progress on the national priorities for health, specifically through the strategy of funding comparative clinical effectiveness research. The research agenda will then help guide the development of an iterative research project agenda, which will be informed by an ongoing stakeholder-engaged input process. The research project agenda is where specific topics reside, such as intellectual and developmental disabilities and maternal morbidity and mortality, both of which were specifically identified in Bigquery's reauthorization legislation. The proposed research agenda comprises 6 statements that all begin with fund research that, to emphasize the connection to funding CER. The 6 statements are: fund research that fills patient and stakeholder prioritized evidence gaps and is representative of diverse patient populations and settings; fund research that aims to achieve health equity and eliminate health and healthcare disparities; fund research that builds the evidence base for emerging interventions by leveraging the full range of data resources and partnerships; fund research that examines the diverse burdens and clinical and economic impacts important to patients and other stakeholders; Fund research that focuses on health promotion and illness prevention by addressing health drivers that occur where people live, work, learn, and play. Fund research that integrates implementation science and that advances approaches for communicating evidence so the public can access, understand, and act on research findings. This research agenda will be open for public comment through the end of January, and I urge you to submit your input for our consideration. Other things that we have been working on rolling out at Pcori include the provision of our reauthorization that authorized our full collection of the full range of outcomes data, meaning that future Pcori-funded research can now include consideration of economic impact of health interventions. This means not only traditional measures of utilization and costs, but also a specific focus on the non-medical costs to patients and families, such as caregiver burden, workplace productivity, and absenteeism. It's important to note that this language does not remove the statutory prohibitions on Pcori establishing cost per quality adjusted life year, QALY thresholds, or allow Pcori to conduct cost effectiveness analyses. Pcori has been working through an approach to this new provision that ensures transparency, notably patient engagement throughout implementation, considers the full range of treatment options, develops standards about identifying, capturing patient-centric cost data, addresses concerns around the use and misuse of cost data that could lead to cost effectiveness or inappropriate value assessment, and hopes to expand beyond traditional health economic perspectives on cost and value. To guide the use of this data, we have developed 4 principles. First, considering the full range of outcomes important to patients and caregivers, including burdens and economic impacts, is central to Pcori-funded research. Second, Pcori-funded research may consider the full range of outcomes relevant to other stakeholders when these outcomes have a near-term or longer-term impact on patients. Third, the collection of data on potential burdens and economic impacts of treatment options must be appropriate and relevant to the clinical aims of the study. And finally, fourth, Pcori may support the conduct of certain types of economic analyses as part of a funded research study or independently to enhance the relevance and value to patients and other stakeholders of information Pcori-funded investigators collect on potential burdens and economic impacts. To further support our research in appropriately collecting and using this data, we are establishing an economic resource center that will provide further technical advice and guidance. In addition, we will be funding a series of engagement awards that provide program support to further exploring the topic of economic impact data in research. In other new developments, we recently held a request for information on the science of engagement. In this RFI, Pcori sought input to inform the potential development of a science of engagement funding initiative. Science of engagement is the systematic study of methods for and outcomes of engagement to inform high-quality, patient-centered research. Expanded funding for science of engagement could address high-priority knowledge gaps on approaches for effectively engaging diverse stakeholders throughout the research process. The Science of Engagement initiative could potentially involve 2 complementary, interrelated research program approaches: standalone research awards on engagement in research and studies within a study for ongoing PCOR CER awards. The intention of these complementary mechanisms would be to help create a strong evidence base of answers to critical research gaps that could be addressed to make engagement more effective and widespread. And as always, we continue to focus on improving the science of engagement in many ways. We've also developed a series of learning resources found on our website that can be used by researchers to help them succeed in conducting research in multi-stakeholder teams. It addresses 2 key areas: engaging stakeholders to be active members of the team and working together as a productive team. We've also developed a Research Fundamentals program, which is a free comprehensive training package that offers different ways to learn about the health research process and be involved in patient-centered outcomes research. It's designed to help you understand the language and logic of the research process in an engaging and easy-to-grasp way. These new resources encapsulate what we have learned to date to support the practice of engagement. Pcori is always looking at how to fill gaps in evidence in the science of engagement to continue to support our awardees and stakeholder communities in PCOR. I'd like to thank you again for having me and reiterate Pcori's support for patient-centeredness in all research initiatives. We believe this is a core value of our health system and is at the heart of everything we do here at Pcori. I'll also leave you with a plea. Please submit your comments about our draft research agenda and spread the word far and wide with your colleagues and contacts. You can submit comments through our website either through formal written comments or through more informal methods, including leaving us a voice message. This is a really important way for the community to let Pcori know what they care about, so please spread the word about this opportunity. Thank you again, and I wish you all the best in the rest of your forum. Have a great day.
Welcome everyone to our 12th annual PIPC Forum. We're so glad to be doing this another year. I can't say that I agree with Tony more. It's just been like time flies. I can't believe it's already our 12th year. My name is Sarah Vangertruden, and I serve as the Executive Director of the Partnership to Improve Patient Care, also fondly known as PIPC. When PIPC started in 2008, our goal was to foster comparative clinical effectiveness research so that people with lived experience were participating at every stage of research. And today you heard from Caitlin McCormack over at Bigquery about the great work that they're doing around the science of patient engagement, which is so important. And now they're also looking at how they collect data, including economic data, which we're also really excited about. Like her, I hope you will take a look at their research priorities as they come up and comment. I know that we plan to do so as well. But during our discussion too today, we want to focus on the National Council on Disabilities efforts to raise awareness of the use of quality adjusted life years and discriminatory metrics and value assessment, and what that really means for people who are trying to get the care that they need. In the email that you received with the link to this event, you'll find bios for all of our participants today. So I'm going to be providing, sort of a short snippet of their bio. And you also will get you got some background information about the methodological flaws of metrics like quality adjusted life years, just some background information to better understand what those metrics are and how they inherently discriminate by devaluing the lives of people with disabilities, chronic conditions, and older adults. But without further delay, I would love to introduce now our first panel so that we can get their perspectives as representatives of patients and people with disabilities. And so first I'm going to introduce Megan Moyer. Megan is Disability Rights Oregon's Public Policy Director. She leads the organization's efforts to promote the civil and human rights of people with disabilities and people with mental health conditions through legislation and policy advocacy. Over this last year, I've had the opportunity to follow how effective Megan has been in her work in Oregon with the legislature and with the Oregon health system, which you're going to hear a lot about today. We also have Jen McNary with us today. She's a trusted voice in the rare disease community and the mother of sons with Duchenne. She's a public speaker and a fierce advocate. We have all witnessed that. She organized the largest FDA advisory committee hearing in history with over 1,000 Duchenne advocates, families, clinicians, and researchers in attendance. And for all you patient groups, you know what a big deal that is. Currently, Jen is the head of patient advocacy and engagement at Fulcrum Therapeutics and is consulting in the biotechnology space as an expert in caregiver and patient engagement. So we're really excited to have Jen here today as well. So Megan and Jen, you can take yourselves off of mute, and I'm going to sort of just dive right in with an introductory question. And if I missed anything in your introductions, feel free to add some flavor to that. But I want you to tell us a little bit about your real life experiences with QALYs and the states where you live, and what that has meant in terms of coverage, access to care, that kind of thing. So Megan, maybe we could start with you, and then Jen, we'll move to you.
Sure. Oregon has for 30 years operated our Medicaid program under an 1115 waiver, which allowed us to design our own approach to our Medicaid population. And in many ways, it was innovative and cutting edge. One of the ways was that Oregon has strived for 3 decades to cover more people than what the federal government requires. We have always valued children having access to care, people who are low income but have not traditionally been able to qualify, people with disabilities. So there are things that about Oregon that are really great and strong when it comes to how we've operated our Medicaid programs. Unfortunately, in order to get waivers, you have to show that it is less expensive for the federal government to grant your waiver than if they were to just fund a traditional Medicaid program. And the way that Oregon accomplished that was that they made a policy decision 30 years ago that we would cover more people, but we would offer less care. And those are really hard decisions. And there are pluses and minuses to both approaches. Oregon has always valued preventative care and done a very good job of covering preventative care in a broader sense than Medicaid does historically. But when it looked at how it was going to prioritize what it was going to cover and not cover, Oregon implemented what we call the prioritized list. And in order to compare apples to oranges, Oregon needed a metric to score conditions and their treatments and then rank them. And here's where QALY came in. Even though originally Oregon said, hey, we're going to use QALY, we'll use this score, we'll figure out what we can afford, and then we'll have a cutoff. The federal government, when we originally applied 30 years ago for our waiver, said, no, you can't use QALY, that's discriminatory and it violates the ADA. So what Oregon did was it said, okay, we're going to make our own scoring formula, but they use QALY in that formula. So as it created a score, it ranked different things, and one of the multipliers was the QALY score. And what that resulted in is that Oregon has a list, and right now we cover the top 471 diagnoses on this list get coverage, and anything below number 471 that we do not treat. So if you have a condition that falls on number 472, there is no treatment at all for you. And unfortunately, there's also no appeal process because it is cut and dry. We either cover it or we don't. The fact that we've approached it that way and our scoring is biased against people with disabilities, that's resulted in people with disabilities here in Oregon disproportionately not having their conditions covered. And so that impact has been huge. There have been many instances where families have been fighting in the Oregon legislature and other places because they simply could not get access to care that, if they had private insurance, would be covered. So that's kind of Oregon's background with how QALY impacts our care.
So we're going to come back to this. The whole idea that you don't have an appeals process is a bit appalling to me. Jen, I want to give you a chance too, though, to just provide some background on the work that you've been doing and what you see in Massachusetts.
Sure. Firstly, I have to say that I'm speaking on behalf of myself and my family. We left that piece out, but although I do work in biotech and held a number of volunteer positions, I'm speaking about my children and my experiences. And also, Megan, I wish I had known you when I was advocating for a family in Oregon for coverage for a Duchenne drug, but I'm happy to know about the work that you're doing. In Massachusetts, we have this unique situation where we are in an innovator state. This is where most of the biotech companies exist, and we really support innovation in theory. But unfortunately, what I've seen time and again in Massachusetts in practice, all of our patients who have a life-limiting condition, like my two sons, Austin and Max, have Mass Health, Mass Medicaid coverage. And even my 14-year-old son, who has immune deficiency, qualifies for Mass Health coverage. Unfortunately, they are utilizing many different ways to deny or decline new innovative medications that often come right out of companies that are in Massachusetts. And my personal experience is that my son, Max, was in a clinical trial where the actual literal accelerated approval came as a result of, in part, his muscle biopsies. So we knew that this drug specifically worked for this specific kid. And so no amount of data was at play here. The FDA deemed this drug appropriate for use in this patient population, but yet we experienced multiple denials based on the fact that Max had stopped walking since getting out of the clinical trial. And so Massachusetts was utilizing, prior to any kind of written in stone policies, they were utilizing just that cutoff, that arbitrary cutoff, as once a patient stops walking, they no longer deserve a treatment that might preserve the rest of their function. Now, for reference, he stopped walking a lot later than most people do who have Duchenne. The drug was working, it was slowing progression. But when it came to Mass Health, even with multiple appeals, the pharmacist and the nurse that were sitting in the meeting of the appeals with myself, my son, our doctor, our lawyer, We're saying that according to reports, there is no value. They did not name the ICER report, but according to reports about Duchenne and about these drugs, there is no value, zero value, even with a therapeutic that cost nothing, unless this could make my son walk again. And so, you can imagine them then saying in the next breath that these practices are not discriminatory, because that is the very description. This is the definition of discriminatory, saying that now that your son cannot walk, we will not cover it. And the sad part about this is, even though they consider having a positive policy, they do cover Exondys, they do cover steroids, they do cover a number of therapeutics for Duchenne in Massachusetts. If you have mass health, as soon as you stop walking, you're no longer covered. And so you then become devalued as a human being. So it's incredibly enraging. It's a policy that is very much discriminatory against patients.
And so you were not able to get any insight as to what, like, specifically, I mean, because this is one of the things that comes up, I know, in a lot of our conversations, where states will make comments like that, but we don't know. I mean, we assume they're using an ICER report, right? But the level of transparency in terms of the evidence that's sort of underlying a lot of these decisions, I can just tell you, I've struggled to understand, even when I want to glean, okay, what exactly is it that a state's from, like, I can't find it. So is that essentially where you are in Massachusetts?
So, and I say this really about every state, but Massachusetts being the place that I live, that is a problem. The practices and the way that these drugs are evaluated, that these decisions are being made, are not transparent. They don't tell you where they're getting their information. It is seemingly arbitrary. And so saying that this doesn't benefit a certain patient population, when the label that the FDA provides for an approved therapeutic really should be what's followed. And, the other piece is that, and I know we're going to talk about this later, but, organizations that give that give recommendations to the pharmacy and therapeutics, or the DUR committees, they don't really see the downstream effect of saying that there isn't value to this therapeutic. They're kind of stuck in that scientific box, much like Megan was describing, where people think they've come up with a system and a formulation that works. Downstream, what they're saying is that, this arbitrary decision is being made. There's no transparency. So how can a patient advocate for a change if they don't know why these decisions are being made? And we were lucky enough that we found other methods of coverage, free drug programs and other, but for those patients who were never in a clinical trial and are just diagnosed today and are non-ambulant, they will never receive access.
Wow. Okay. So Megan, I'm just thinking about the 1115 waiver process that you're going through then with the renewal coming up. What are the primary asks then that are coming from the disability community in light of, the inability to appeal to me just seems like such a...
We have two asks that we are working on through our waiver application. One is that we want Oregon to not be allowed to look at QALY at all in our decision-making process. Like Jen said, there is a level of ambiguity about in what ways these scores are used. We have gone back and forth with our, what we call the Oregon Health Authority. They run our Medicaid program, about how they use them, when they use them, are they still using them? And that is very gray. They certainly use QALY when they originally scored everything, and they are open about that. Now they're a little bit like, well, we don't base our score on QALY, but we don't want to not be allowed to look at QALY. Trying to understand, did you go back and rescore everything? No, they did not go back and rescore everything. Why, if you don't use QALY, then why would you want to be able to look at QALY? Does it influence staff recommendation, that type of stuff? So we also have this level of exactly what are you doing? How is it being used? There's also some other scoring that happens that isn't necessarily ICER's QALY score, but also really kind of looks at quality of life type metrics. So what we want to do is we want to start by saying, please do not use any QALY at any point in a conversation about what will and will not be covered in Oregon. And so we are asking Oregon to not waive that. We're also asking CMS, please do not allow Oregon in their process of deciding what is on the prioritized list. Do not allow them to reference QALY in any way. The second issue relates specifically to children. And there is a part of the Medicaid law that's called Early Periodic Screening, Diagnosis, and Treatment, EPSDT. And what it says is that Medicaid programs should be covering treatment, screening, and treatment for ages 0 to 21 that are medically necessary. And this is specifically understanding that if we treat many conditions when a person is first diagnosed, often in early childhood, we can maximize their independence and self-determination. And there's a value to that. So when the law passed, there was an acknowledgement that we may want to cover more and do more intervention for children because in the span of their life, it will have significant benefit, both to the individual, but also to society, because that person hopefully will have the ability to maximize their independence. Oregon chose to ask for a waiver from that federal requirement and said, we want to apply that prioritized list we have to children as well. So in Oregon, ages 1 and up, the prioritized list is put in place instead of that broader definition in federal law, which is what is medically necessary. So even if something is medically necessary for a child, their doctor thinks that, experts show that, we could show if we did this intervention, it would have significant improvement for their life trajectory, their level of independence and self-determination. Again, because it's a prioritized list, if it fell below the list, there is no appeal. It doesn't matter if it's medically necessary in Oregon. And where this has come up repeatedly is many conditions, one might say, I understand how it may have gotten that score. We don't agree with it, but it may have gotten a score in an adult population, but it's really very different for children. No, we don't even differentiate in how we score within an adult to child population. Also, if a condition is rare and therefore never got scored, it's either new or so few people in Oregon have gotten that diagnosis that our committee that scores these and puts it on the list hasn't even discussed it, it is automatically not covered. So if you are a person who has a child who is diagnosed with a very rare medical condition, it is quite possible that it hasn't even ever been discussed, and therefore it is not covered. And that would not be true in private insurance that, again, goes off this medical necessity. And if they were to deny coverage, you would, in Oregon, have an appeals process through our insurance commissioner. So we are asking the federal government to say, no, do not allow Oregon to waive this EPSDT federal requirement. There should not be a prioritized list for children up to age 21.
So what I'm hearing, there's a lack of, Oregon obviously was feeling the heat about using QALYs and now is sort of being subtle about it. And then, or, maybe not so subtle. And then on top of that, the use of the QALY is just, the impact just sounds like it's exacerbated for children because you have this added EPSDT waiver. Am I correct? Oregon's the only state in the nation that has that. Is that correct?
That I know of, yes.
Wow. Okay. So Jen, I'm curious because in Massachusetts, I was reading your Boston Globe opinion piece recently, which was so well done. And I'm curious, if you could just talk a little bit about you know, and having gone, I mean, I can't imagine as a parent, you see your child succeed on therapy in a clinical trial, and then you're in a state where they're saying, oh, no, but we're not going to cover it, even though you have proof of, I mean, you have proof that it works firsthand. I want, you know, can you just share a little bit about that, and then share, you know, what that then means in terms of your advocacy in the state? Because I know the state's also been looking at a potential QALY ban. Like, maybe you could talk a little bit about.
Yeah, I mean, I think that, you know, it's devastating, and, you know, we could go way deeper than my kids, right? It's kind of threatening innovation. You know, it's specifically targeting drugs that are approved specific for the rare disease community via accelerated approvals and others. You know, some of these bans or these QALYs reports, like the Duchenne one, they mention a lack of data, right? And so those are specifically targeting those drugs that are created and approved based on accelerated approval for the most vulnerable populations. As you mentioned, there is a bill 201 for a full QALY ban in Massachusetts. I will say that advocating in Massachusetts, again, I'm a pretty well-connected human being. Advocating is cumbersome. I did register to speak and testify. I had to submit my testimony in writing because my registration somehow was lost, and so we countered that with an op-ed in the Globe. I also serve on the state rare disease advisory committee, so that we are heavily engaged in these topics. So I'm really hoping to be able to weigh in. I think that the major issue, again, comes back to transparency. I don't know that the general public understands what our Health Policy Commission is, our HPC. We haven't had time to touch on that, and I know that we're running a little behind, but the HPC is formed in Massachusetts to make recommendations to the DUR, and those recommendations are going to be based on QALYs, and they're going to be based on ICER reports. In fact, there is an actual contract between HPC and ICER, and so folks don't know that. So how do they lobby against it? There can't be a broad opposition because advocates are blinded to it. And so a lot of what I try to do is introduce folks to this topic. And when you do talk to the folks at HPC, again, they see disconnect between what they're doing crunching numbers and how those numbers and recommendations actually impact folks in Massachusetts, patients that they're talking about. The whole job of HPC and of Medicaid, every Medicaid, is to preserve money and valuable state budgets and make sure that they're, you know, saving those spends. They don't have a lot of money, but denying life-saving medication for disabled individuals should not be, you know, kind of that first look or first step.
That's really helpful. You know, I mean, I'm hearing a lot about just understanding and knowing and transparency of the evidence base and need for better engagement strategies. I know we are running out of time, but I have one more question that I hope we can end on, and that is, because we all were watching Andre Gallegos and his presentation about QALYs, and I hope that, I mean, what would you say to Congress about this? I mean, NCD is advocating, obviously, for kind of just an unambiguous, as they say, QALY ban. I mean, what do you want? What would you say to your members?
Are you going with Megan first?
I'll go first. You know, I think what we're communicating is we are not against innovation. We are not against having to look at cost effectiveness in some ways, but it's when we try to quantify or numerate a concept that is by definition not definable in order to make these decisions. And the people doing that are known to be biased against people with disabilities. I mean, I don't need to tell this community that the healthcare profession has a bias that defines somebody's worth by how healthy their body works, which to me is mind-blowing. I have probably not had more health problems until now in my life. I have a chronic condition. I have I experience disability, and yet I am probably the highest functioning, greatest contributing I've ever been. So this idea that we're going to put a number that is a multiplier in deciding who gets treated, what is worth the cost, and that number is going to be presented as if it's evidence-based or as if it is not biased. And then we're going to make our decisions around treatment based on that is fundamentally discriminatory. And so what I am hoping the federal government will do is say, as we engage in hard conversations about the care that we are going to be providing, we need to do that while being honest with what these metrics are telling us. And we need to make decisions, and we need to be transparent about making those decisions based on what is objectively, factually accurate, and not based on our perceived perceptions of the quality of someone's life. That is not an acceptable multiplier. It's not an acceptable data point to be considered. There are hard decisions that have to be made. There is a finite resource of money that is put into place. And so we don't expect that there aren't going to be hard choices. We don't expect that they won't look at cost effectiveness, but it has to be done in a way that is unbiased, that does not discriminate against people with disabilities, and looks at how bias has played in to health inequities today. You know, I look a lot about, yes, people with disabilities are clearly impacted by scores like QALYs, but so are people of color, because they have experienced poorer quality healthcare that has resulted in poorer health outcomes. And because they've experienced that systemic racism in healthcare, they have lower life expectancies. And therefore, when we multiply treatments, that when we look at treatments that impact people and how effective they are, the number of years of life that they're going to benefit from a treatment is lower because they have suffered chronic discrimination, and we're perpetuating that. So these are hard conversations, they're highly technical, but it really requires a level of openness and transparency and debate about what is bias and how do we remove our preconceived notions about quality and about the value of life from those hard conversations. So that's my what Congress should do. Good luck. But when in doubt, ban anything that is judging quality of life.
Jen?
Sure. I mean, you said it very well, Megan, and I was going to take it back to the people too. I think that that's our job as patient advocates. And so let's bring it back to the human beings that these policies actually affect, which in my life are my adult sons, who arguably my oldest son, who's 23, is a much more productive human being than I ever was. He's a co-founder of a nonprofit for young adults. He's a public speaker. He's an activist and an advocate. He's going to school for mechanical engineering and biomedical engineering. He is an independent human being with a lot of intelligence, and he's also kind of a funny, cute kid. And they're living in their apartments. They, because they've had access to drugs through clinical trials, they live in an apartment. I don't see them every day, which is phenomenal because these guys are living lives as independent adults living in wheelchairs, despite the fact that they have incurable and terminal illness. So I would challenge anybody that is a decision maker to think about these people as kind of those throwaway kinds of people and really think about them as human beings that want to live their best lives for as long as they have a life. So it's about quality and not quantity. And then finally, in the words of one of my heroes, and Dr. Janet Woodcock is my hero, she has said to me, we've had conversations about this issue, and she has said, when you are looking to make budget cuts, do not start with access to innovative therapies for chronically ill people. So we all recognize that there's a problem, but I like to repeat that line often said with anger and said with encouragement as well.
You guys are awesome. Thank you so much for being here today. I know we're running a little bit late. I hope everybody can stick with us. But I'm going to just move on, and since we've had this wonderful conversation to understand sort of the real world impact, right? I want to introduce our resident experts who are really the thought leaders thinking about, okay, if not QALY, what? How do we do this better? What are we thinking about in terms of better patient engagement? And I think about what Bigquery was talking about earlier around the science of patient engagement and the methods, right? Because that's where we hope we're going next, right? So I'm going to first introduce Dr. Elizabeth Orline, Assistant Vice President of Research and Programs at the National Health Council. She is a mixed methods researcher with expertise in value health technology assessment, outcomes research, patient-focused medical product development. And today she's going to present to us information on the National Health Council's work related to value assessment. And then we're going to hear from Dr. Richard Z, a health economist serving as the Health Economics and Outcomes Research Manager for the Innovation and Value Initiative. And he is going to present to us information about the work that's being done at IVI, which is also very focused on how we capture the patient voice and value. So I'm going to start with Elizabeth, if you don't mind. I think we have her slides.
Sarah, you're on mute.
Oh, sorry. Just direct us when you need us to move the slide forward. Sorry. Thank you.
Great. Thanks so much, Sarah. And thank you to those who presented early. I really appreciated your remarks. And also bringing this back to what's so important is thinking about the individuals who can be impacted when value assessment isn't done in a patient-centered way. So I'm just going to wait on my slides, but I can just go ahead and get started by centering us about, what's the goal that we should all be working towards? And I think we're very aligned that it should be facilitating access to treatments that patients need at prices that they can afford, and that we would acknowledge that there's really nothing worse than having effective treatments available, but not being able to have equitable access to them. And so, this is a conversation about methods. And so I think it's helpful also to start off with what's the definition of value assessment, and what are the different potential methodologies that can be used to assess value of treatments, of surgeries, of hospital-based care, and so on and so forth. And so I think it's really important that we remember that we're trying to bring together folks with all different types of backgrounds. Value assessment should certainly be multidisciplinary, and we're wanting to evaluate clinical, economic, social, organizational, as well as ethical issues for a specific health intervention or health technology. That might be a drug or a surgery, something else. And it can involve a review of the clinical evidence. It can involve the review of healthcare costs, and then social and ethical impacts on the healthcare system and the lives of patients. And so it's important to also acknowledge that the current methods that we use to conduct value assessment all have limitations. And so at the NHC, we're really focused on identifying and promoting patient centricity and value assessment across different methodologies. And so we've been working on this by preparing patients to engage in conversations around value assessment, partnering with members of the research community to improve methodologies, advancing the data environment to ensure it supports patient-centered value assessment, and then certainly also pushing for transparency in analyses as well as decision-making. And so you can see here on this slide, this is the National Health Council Value Classroom. And the intent of this is really to provide a free resource for members of the patient community, as well as others who are new to value assessment. And what we've tried to do with this website is to present, we've got our course, which is a series of online modules. That's Health Econ 101. We do have one of the modules about the mysterious quality adjusted life year that I think does a pretty nice job of explaining the intricacies of how it's used, what some of the challenges can be in terms of the data that goes into actually calculating a quality adjusted life year, as well as the larger, how it fits into a larger cost effectiveness analysis. So that might be of particular interest to folks, but there's also other topics included there. We have a glossary, and then we have a number of other tools. And so these are really helpful, especially in the case of, if you are representing a chronic condition, patients with a chronic condition, and there's a value assessment that is about to happen. That might be ICER conducting a value assessment. It might be partnering with IVI. You'll hear from Richard in a couple of minutes. But it's intended to provide resources for you to get ready. We've got the Get Ready checklist, which is part of it, which discusses some data collection partnerships you might want to consider, as well as thinking about how do you write really effective comments if you're actually reacting to a specific value assessment. And so that would be within our considerations guide. And I'm happy to pop a link to that in the chat in just a minute. We can go to the next slide, please. Okay. And then I mentioned at the top that another, huge part of our effort in terms of enhancing patient centricity of value assessment is really in terms of methods development. And so here I've listed out a number of our collaborators within value assessment specifically. You can see, on the left is a white paper that we did, and this was about multi-criteria decision analysis. So we've spoken a lot about quality adjusted life years as one type of input into a particular way of conducting a value assessment. But there's other methods as well. And so it's really important that as we're evaluating any possible methods for conducting value assessment, that we're keeping those same things in mind as, is this a patient-centered methodology? Are the data that are being used as part of the assessment patient-centered? Is the output being presented in a way that's understandable as well as transparent about limitations? And so that was an approach where we wanted to look at MCDA as a method. You'll hear much more about the work IVI is doing in that space. But we have a number of other ongoing initiatives and partnerships. Health Technology Assessment International is a professional group, and it might be of interest to folks on the call that it's an opportunity for us to also work internationally on these issues. HTA, or value assessment, has been used in other countries around the world as well for a number of years. So there's some good insights that we can glean from approaches to patient engagement and data collection methods from those abroad as well. And so I am actually going to stop there because I know we're running a little bit short on time, and there's a couple of questions later that we want to go through. So if we go to the next slide, you'll be able to just see my email address. Happy to follow up about any of these, but otherwise I'll turn it over to Richard.
All right, Richard, we're going to get your slides up here momentarily so that you can also present some information to the group, and just excited to have you both. Thank you.
Thank you for the invitation, and thank you, Elizabeth, for a great presentation to set the scene. Can you guys all hear me okay?
Yes.
Hi, good afternoon. Oh, cool. Good afternoon, everyone. It's a great pleasure to be here today. My name is Richard. I am the research manager at IVI. So for my presentation today, what I wanted to share with you guys is some of the novel approaches to advance patient-centered value assessment in the United States context. So to start off the presentation today, what I wanted to share with you is the set of 9 principles that IVI has developed to inform or guide the methods that will provide insights to value assessment in the US context. So I won't go through all 9 here, but there are 2 I especially wanted to highlight today. One is sustain authentic patient centricity. And what this means, which I will illustrate with some examples in a little bit, is that the patient voices, the patient input, needs to be incorporated and solicited throughout the development and application of these methods. The second thing is health equity. So the COVID pandemic has really highlighted the widening disparities in our society. And very often we focus on population averages, but we do not really look into the subgroup-specific inputs and also the implications of policy on disparities across subgroups. So there is also a need to really incorporate the equity considerations in anything we do. So these are the two I wanted to highlight. And now I'm going to go ahead and share some examples with you. Next slide, please. So one of the major initiatives at IBI is the open source value platform, which is kind of like a little laboratory which we use to test novel methods and approaches. So our current effort is a multi-stakeholder engagement effort to develop a value platform for people with major depressive disorder. And this platform really has two modules. One is the health economic module. The second one is the multi-criteria decision analysis module, which Elizabeth has also mentioned. So for this effort, there are three uniqueness about this effort that I wanted to share. The first is we have actually convened a group of 20 members, advisory group, who comes from different stakeholder perspectives in the United States. And from the outset, they guide us through this model development. And the point here is to really incorporate the decision context and inputs, from different stakeholders in the US. The second thing is, in parallel to developing this model, we have a collaboration with researchers from Pace Center at University of Maryland. And what we're doing there is to directly elicit inputs from a very representative patient sample and make sure that these inputs are incorporated into our both modules. And thirdly, for people, the general public, we also set up multiple points throughout the milestones for this project. As a matter of fact, right now, today, we're launching our public comment period for our draft protocol. And we have tailored in a way such that different stakeholders can provide input, especially the patients. So these are, some of the ways in which we're hoping to test and see how we can change the value assessment models. Next slide, please. So as you guys gather, an important part of our research portfolio is how do we crowdsource patient input and then put it into these methods contexts. And I only listed two examples here. One is economic modeling, the other one is MCDA, and those are two big areas that we're pushing on. But there are much more than this. There are other methods. So the challenge here from our standpoint is really two things. One is how do you operationalize this? The second thing is by incorporating these inputs, what difference does it make when it comes to decision context? So, next slide, please. So a very specific example I want to share with you is one of our ongoing collaboration with researchers from Brand Corporation. And what we do here is we try to use goal attainment scaling, which is a well-validated survey instrument that just talks to the patient and asks them about what their goals are. And what we're doing here is we're exploring a model where we're training the patient advocates or the patient representatives in different communities, and then they can do outreach to more patients. So it's kind of like a hub and spoke model, as you can see here. So and through doing this, we're hoping to crowdsource patient goals and then aggregate it into these more population-based methods. And in this context, specifically, is MCDA. So to inform as a criteria and the weights for different criteria that you will use to solve the decision problem. So that is one example here. And next slide, please. I'm sorry, I'm rushing through all these things. And the very last one I want to share with you is not only do we want to test these methods, throughout this process, we also want to share our learning, but also make sure that we hear from different stakeholders. So one of the very exciting initiatives for IBI lately is a Bigquery-funded Methods Summit. And this is a summit that's really focused on how patient preference data can intersect with health equity. We're still digesting the findings from this Methods Summit, but there are two very important learnings that I wanted to share today. One is we should really work with the patient communities about defining the meaningful impact of a disease and its treatment. The second is we really need more specific methods and metrics that can inform value assessment and comparative research. So on that note, I I hope this gives you a sense of, how we are pushing for more patient-centered value assessment in the U.S. context. And now I'm going to end my presentation here and happy to engage in the discussion.
That was great. Thank you so much, both of you. When I hear you speak, I mean, because we often get this, oh, there's no other way to do this, assumptions. And I come back to something that Megan said, and when Megan and Jim were sort of in their final comments on the last panel, what is it? I mean, why can't we get past this sort of QALY issue? I know when oftentimes in audiences of health economists and academics, they'll say, well, QALYs are the gold standard. This is, it's sort of like this is what they're educated to do, and they don't understand why we don't think it's okay, And I think on this, where we hope that everybody's learning, but what's the holdup? What do you think is the problem getting past this metric so we can get to what you're doing, which seems so much better?
Perhaps I can.
Why don't you start?
Sarah, you're muted. Perhaps I can start here. Yeah, sure, absolutely. So I think from my perspective, I think I'm thinking from the context of decision maker. There is a need for them to aggregate the individual inputs. There's a universe of data and input out there. So there is that need to kind of simplify and aggregate to some decision rules that will allow us to make more informed decisions. And here I also want to take a step back to think about QALY itself. And by the way, I totally agree with what the previous speakers have said. And I think it's well acknowledged, in the research community and also end user community that QALY has its limitations and all the discriminatory implications. But if you think about QALY conceptually, originally it was a beautiful concept because if you think about the health benefits, you can really think in two dimensions. One is, life expectancy. The second is the quality of life. However, it is in the measurement of these different aspects that it has all these unintended consequences. So I think the bigger issue from my perspective is the over-reliance, on one metric to inform decision. Because every metric, every novel method will have some sort of limitations. So what is really important is for decision makers to really consider a comprehensive range of outcome metrics. And whether QALY is included or not, that is depending on the specific context. But there are all these clinical economic metrics that the decision makers should consider. So for example, in IVI's MDD model, what we do is we have 10 to 12 metrics that the decision makers can compare and look at them. So the danger, I think, from my perspective, is because of the limitation. If you rely on one metric overly, then it might lead to consequences such as disparities and discriminatory coverage policies.
So I'm happy to chime in too, and I agree with Richard. I think one of the challenges has been with cost effectiveness analysis or QALY-based measures is that it's somehow kind of morphed into something where it is the decision instead of a tool that can be used as part of decision making, where you might have 5 or 6 different sources of data, and then you say, oh yeah, that's helpful, but what I'm hearing over here is a little bit contradictory to that. So we're going to land somewhere in the middle. And so I think that would be a more productive way of talking about and using quality adjusted life years or cost effectiveness analysis as part of value assessment would be to have that more nuanced, transparent conversation and to be very clear that, oftentimes the data underlying how QALYs are being calculated really isn't that great. It's not something that we would necessarily want our own decisions being made off of. And so I think we need to be really clear about that also as researchers that, it's the survey instruments that are used as part of calculating quality adjusted life years oftentimes are generic measures that aren't intended to or they're intended, but they may not be very high quality for disease-specific decision making. And so I think there's a lot of folks, many of the folks on the line have been out saying, you guys need to pay attention to these issues. These aren't little things that we can just let slide, especially if this is going to be something that's really guiding decisions, in my opinion, inappropriately so. But I think, Sarah, your point is, many of us who have been trained in pharmacoeconomics, we did learn these types of analyses as graduate students. And so, they're comfortable. I think one of the other challenges and is really in the importance actually of working kind of on the international level with groups like HTAI as well, is to see that, it's one model. NICE in the UK uses this model. Some of the other HTAs abroad use cost effectiveness analysis, but some of them say absolutely not. That is not something that we think is appropriate for decisions within our country, and we're not going to use that particular type of analysis for our decisions. So I think it's really helpful for us to learn from those experiences and to try to take some of those insights here as we're expanding the methods. And then finally, I'll just close with, I think that the efforts that Pcori now is going to be funding in terms of enhancing the data landscape will be so helpful for us in terms of making analyses that, even those analyses that use cost effectiveness or QALYs, making those better reflect patients' experiences and costs that matter to patients, which is obviously a very important input into all of this. And then also multi-criteria decision analysis, making sure that we actually have the data so that we can conduct these analyses more quickly. We don't have to go out and try to go over here for this data source, over there for that data source. And I'm sure Richard has many more perspectives on that, as somebody leading much of that work as well.
Elizabeth, if I may just also echo your last point, is I think the challenge, for example, at IVI is also exactly as you said, how to operationalize and demonstrate the impact. And Sarah, I think that might also answer your question about why that inertia, why that resistance change, because some of these novel methods do need to be demonstrated, do need to be tested before we can put them into practice. Yeah.
Yeah, I mean, and listening to this, I think about the work that you're doing and how, were it not for work like what the National Council on Disability is doing to highlight how the QALY fundamentally discriminates. And I liked how Andre Gallegos described it as both in design and impact, right? But were it not for that advocacy and were it not for efforts to try to take the QALY equation out of decision-making, would we be in this place where we're actually starting to have discussions around alternative methods, better methods, right? I mean, looking at Pcori, one of the most exciting things about Pcori to me is that, especially now with their reauthorization statute, they're much more engaged now in this methods discussion, because there really is no good standards for what a good method looks like, which we need, I would think, right? I'm curious what you think about that.
Yeah, I think for me, one of the kind of most impactful things that has stood with me was a patient advocate who said, I think we'll know it's good enough when an individual patient picks up a value assessment and says, it's not perfect, but they did a pretty good job of reflecting my experiences in this analysis. And so the further that we can get towards that sort of gold North Star, I think that the better off we'll be. And I think, that's what the advocates on the line are pushing for, is we understand that we need a sustainable health environment. We understand that there are going to be trade-offs that need to be made. But we also need to make sure that if there are treatments that are available that have been approved and have been shown to be effective in populations, that we've just got to figure out a better way of making that clear and making that come out in decision making as well.
And I absolutely agree with Elizabeth. viewpoint. So, and I think as you can see from IVI's work, and that's also something we're trying to do, is to engage patients throughout the process, to translate the technical language in a way such that, we can get patients' feedback and buy-in in the design of these methods, and also to ensure that the insights can also benefit the patient community ultimately. And of course, throughout this process, what we're doing is also, for example, even for areas which we don't have data inputs on that matter to patients, we should, build in, for example, in the modeling context, like structural considerations or placeholders. So this way we can highlight areas where this gives the research community a kind of a future area, for potential research and highlight all these gaps. So, so I think that's largely based on our experiences too.
Yeah, I think one thing I'm hearing then, and I think everyone agrees on, is this concept of patient engagement, right? How do you capture the patient voice? How do you make sure that we're looking at caregiving costs? We're looking at whether or not you can go to work, right? Or, but then again, for some patients, it's, can I sit up in bed? It is not a one size fits all. I appreciate the work that you're doing in that regard. I'm curious, from your perspective in terms of methods, right? Like, how do we get to a place where we just have better methods for getting that patient voice incorporated? Because we're really not, and the types of quality, especially in the quality-based analyses that we see out there, we're not doing a good job. I think we can agree on that, I hope.
Yeah, I think so. For at the NHC, and also, in largely in partnership with IVI and others, is we've been leading 2 initiatives to improve the methods collection, or methods for data collection. One of them is we just released on our website a patient experience mapping toolbox. And what that includes are interview guides and visuals to help researchers do a good job of comprehensively understanding what are patient experiences before getting a diagnosis, while getting a diagnosis, and then living with and treating a chronic condition. And that includes, costs, access, barriers, care coordination, all of that. And so we've put that on our website, and that's available for free for anybody to use. And so I think that that's one step towards getting more predictable and standardized way of gleaning qualitative information, which I think has been sort of a barrier, is that that's been all over the map. Another effort that we're leading in collaboration with IVI as well as EveryLife and many others who have joined the project now is to develop an approach for patient-centered core impact sets. And so to your point, Sarah, that there's all these different impacts that really matter to patients, and those might be disease-specific or they might be across the board. And so what we're trying to do is to identify what are those impacts? And that's very deliberately broad so that it can include health outcomes, and it can include costs of care. It can include things like modifying your car because you need to accommodate a wheelchair or something else. What are those things that matter to patients? And then to ensure that those that data on those impacts are consistently collected across studies, so that once they get to the health economists, once they get to the others who are going to be analyzing information as part of value assessment or as part of clinical practice guideline development or all of these other potential uses, that it's coming to them in a way that's structured and that reflects what matters to patients, and that it's high quality enough that we don't keep running against this wall where it's like, well, I hear you that that's important, but I just don't have data to support that, which, makes all of us want to jump off a bridge sometimes and say, what are you talking about? Your data is not high quality either, but you're very comfortable using that. So so that's, my 2 cents and some of the work that we've been doing in this area as well.
And to add to what Elizabeth said, the first thing is I'm really excited about the patient core impact, and I think it's really going to provide a blueprint to guide, the different disease states, and as different researchers think about values assessment, the different parts of that process. What I will in addition share is, 2 specific examples in which we're trying to operationalize, patient input in the context of value assessment. One of them is the goal attainment scaling that I briefly introduced in the presentation. The second is our collaboration with researchers from the PACE Center at University of Maryland. And what we're trying to do there is to elicit a set of treatment priorities for patients in a disease state of major depressive disorder. And then we're trying to see in what ways can we incorporate that as in the economic model. This could be an outcome. This could be a structural consideration that reflects patient journey. So these are just like some of the specific examples. And then I think largely another reflection I've had recently is, at what stage of the research should we really involve patients and engage with patients? And I think we could have done a better job at least two stages. One is in the conceptualization of the study design and the purpose of it. Because very often, as Elizabeth talked about, researchers go to do a lit search and they said this is available data. So we fit a model or we fit kind of approach to available data. But what should really happen is we should understand more of the nuance, of the burden of the disease, the impact of treatments on patients. And then we can triangulate that with available evidence. And that can really guide our research design to make sure that it's comprehensive, it reflects the real world patient experiences. The second part I think that's missing is once we have the results. So if you think about a patient survey study, we collect the input, but we don't really take those results back with the patient community and discuss with them what the implications are. Does this really make economic sense? What's missing? So that's also, I think, a missed opportunity where, as researchers, I feel like we could do better. And that's actually something we're aiming to do in our research project. Yeah.
You guys are awesome. Okay, one last, and then we're gonna end this thing. One last question. So I'm thinking about everything that you're saying because I completely agree, right? You have, and you guys are the masters in terms of thinking about this in the context of methods too. How do you get payers, though, decision makers, people who actually are now taking this information and then translating it into something that makes a difference to whether a patient has access to care, right? How do we get payers to use better information to make decisions? How are we going to get, I guess maybe we don't have the answer, but I'm just curious what your thoughts are.
Perhaps I can start because I think that's the challenge we're facing, in a lot of our ongoing projects right now. And I think two things we can do incremental steps. One is to engage the payers from outside, such as the NDD model, so we know what the decision needs are. And second, because they are involved from day one, it's not a black box. There's a lot of communication exchanges among different stakeholders in that process. So that would hopefully lead to buy-in down the road. The second is I think there's a need to do pilot testing and to demonstrate the impact. So like with the NDD model, a specific example is if we were to solve the same question, what is the insights from a cost-effective analysis? What's the insight from NCBA? What if I considered caregiver costs? How does that affect all these treatment sequences that we should give to patients? So I think by realistically demonstrating this and how that's going to impact more cost-effective resource allocation in our society, I think that's where we get a mindset shift and in the practice of coverage and reimbursement decisions. Yeah.
So I certainly don't have a great answer to this. I wish I did. But one way we've been approaching this is because we really haven't gotten a lot of traction and interest from insurers in this area. But we've been partnering with employers in this area because in many cases, employers are interested in many of the same things that patients are interested in. They're interested in having their employees present. They're interested in making sure that their employees are productive, that, mental health considerations. And, I think we're at a moment right now where we probably have a very good opportunity to get employers even more on board with those types of considerations as they're looking to retain employees, as they're looking to bring in new employees. And so I think that that's one, alternative route to getting at health insurers is to get at the employers and say, you care about this stuff. You're paying for health care for so many people in this country. And let's make it better together. So that's one way that I hope that we, continue to move over the coming years as well.
Well, thanks to you both. I found that very educational. As we wrap up, I just, want to point people back to the website and the email that we sent out that had some resources, but you should also check out the National Health Council and Innovation and Value Initiative websites. They have some really great information there. I can say we're just really excited and grateful too for the National Council on Disability who presented earlier today. I think the presentation from Chairman Gallegos really, I hope, was a good sort of 101 on what's equality, why is it a challenge, and why is the disability community so focused on eliminating its use in our federal programs. And then I'm excited to see, I think some of that advocacy is why we're here today, right? It's why we're having a conversation about developing better methods. So anyway, we're very grateful because there are a lot of great minds and great advocates out there, thinking about this and trying to come up with solutions and to do a better job at the state and federal level. So thank you for everything that you do. We're going to end the forum here. But again, we hope that you'll stay in touch and let us know if you have any questions. Thank you.